Good afternoon, good evening, everyone, and thank you so much for joining this session today on Ask the Experts for Fertility Difficulties. My name is Dr. Ratna, and I run an organization called the Patient Academy for Innovation and Research. We work on a lot of areas, but one of our main focus is women's health. And under this, I have with me my colleague Khushbu, who runs two programs on endometriosis as well as PCOS. And both these conditions share a common concern, which is fertility and challenges in fertility. And a lot of our patients ask us many questions around fertility, the myths and misconceptions, the stigma in the society that exists, and a lot of fears around fertility issues. And we felt it is best to listen from the experts themselves as to how some of these questions can be answered in simple layman language, so that some of the concerns that have been raised in our forums, whether it is Facebook or on WhatsApp, they can be answered by the experts themselves instead of us searching for information on the net, which sometimes may not be very authentic. So it's my pleasure to welcome both the experts to our session today, Dr. Uma Sinha as well as Dr. Hemant Kanodia. We will have two presentations, short presentations from them speaking on two topics, and then we will follow that up with a Q&A session. Our first expert is Dr. Uma Sinha, and she is an MD. She works in Apollo Health City, Jubilee Hills, Hyderabad. She is the founder president of Association of Gynec Robotic Surgeons of India. I did not even know such a thing exists. And she's the honorary professor, Apollo Associate Professor, Macquarie in University, Australia, and a fellowship director at Mars Apollo. And there is a fellowship program that she also runs. She's a board member of ASGRS, Asian Society of Gynecological Robotic Surgeons, and the editorial board GRS, or the Gynecological Robotic Surgery Journal. She has several awards to her credit, and she will be speaking to us on the topic today, which is fertility difficulties. Over to you, Dr. Uma Sinha.
Thank you, Dr. Ratna. Sabse pehle, I will say namaste to everybody. Thank you for joining us today for this, I would say, a very, very remarkable afternoon that Dr. Ratna and Khushbu has put together. It is always a pleasure to directly talk to patients and women about their own problems, because I firmly believe that knowledge is power. Let me start sharing my screen and we will talk about it as we go through. Is my screen visible to everybody?
Yes. Yes,
the screen is visible. Dr. Ratna, is the screen visible?
Yes, I can see your screen.
Okay, great. And I'm audible well?
Yes, ma'am, you're audible.
Loud and clear.
Thanks. So this is just an introductory slide which Dr. Ratna has already shared with you. So let me start by I bring greetings from a kind of old city of Hyderabad, where that iconic Charminar you can see. And I'm also here associated with Apollo Hospitals, Hyderabad, for which I have been associated for many years now, and do basically a surgical management in gynecological problems. So when this option or opportunity came from your organization to talk about fertility or infertility and how are the insights and perspectives for women, I would like to start with a positive note. I know in India, women are very scared about talking their infertility. Or if you are married for a year or two and not conceiving, there will be question marks, eyebrows raised, or something subtly happening around you all the time, and you don't know what to do. You have no clue. So let's start today's discussion or understanding with a change in terminology completely. Let's not talk about infertility. There is nothing like infertility. We talk about fertility. And we talk about if you're having a difficulty in your fertility, how do we help you? So let's remember, underline or inverted comma, all women are fertile. It's only a challenge for some, and we'll come to that. So we start with a positive concept of fertility and how we can improve your fertility. So you have to remember it's actually not rocket science to get pregnant. You need three things. You need the man's sperm, you need your eggs, and you need a uterus. And that's why for years together, for centuries together, women have got pregnant and have given birth. Why would you not? So you could have problems in any of these areas, or you may be just thinking you have a problem, but probably there is no problem. So you need to have your partner or your husband who has good sperms. is able to have a good coitus and ejaculate the sperms in your vagina. That's the basic requirement of the man. You need to have proper ovary function and ovarian aspect where you are developing and releasing good eggs. And then you need your fallopian tubes to come and have the pregnancy. So you need the sperms, you need a good nice egg, and you need a uterus. But remember, you need a smiling and a happy uterus, not a uterus which is not happy, or overall you're not happy, because your mental status and stress makes all the difference. Now come to the basics. You know these 3 facts. Remember another fact. I'm sure most of you who are with us and are trying for fertility have some kind of chart or app to tell you when you are ovulating. But there is a kind of little thing that you can understand. One is, what is the life of sperm when it enters your tract as a woman, and what is the life of the egg or the ovum that you have generated. Now, by and large, ball figure, remember that when you have a coitus or an intercourse, the sperms are released in your body and they're alive for 72 hours. In the 72 hours, if they find a live egg in your fallopian tube, that means the egg has already been released and is in your fallopian tube, it will fertilize it and you get a baby. But when you release an egg as a woman, your egg is alive in your system, ballpark figure, around 24 hours. So now you just do your math and try to understand. If you keep these apps, it may not be very accurate. You may learn that you have ovulated, say, 9 o'clock in the morning today. You may have ovulated last night, but you didn't check. You check now. By the time you actually get through to home, to your partner, get the sex, maybe 24 hours are over. And you don't conceive and you regret that, oh, I didn't conceive, there's something wrong. Everything is about time. So we normally suggest that if there is no other problem which we need to treat, you must have adequate coital frequency or sex frequency during the times when you are going to ovulate. Now, again, I always say, and I tell again, biology is not mathematics. 2 plus 2 is never 4, never, it can be 5, 7, 8, 1, I don't know. So biology can be very varied. So don't calculate like maths or use an app, which is not always true. Use your sense, use the logic. So between 10th to 20th day of your cycle, you may ovulate at some time. Now, if my sperms are going to be alive for 72 hours, that means every second or third day, if I have sex 3 or 4 times in that time, boom, you'll hit the right thing and you get pregnant. So don't keep on doing tests, better in that 10 days, go for a holiday. If nothing is wrong, you'll probably get pregnant. So these are some of the basics you need to understand. Don't become this family. Now, you can't bring out a baby through a printer. You need to have sex. Why am I saying this? Because a lot of young couples today are probably delaying marriage a little. All right, no problem. Once they get married, they delay the childbearing also a little. So by the time they start thinking, okay, let me think, you are about 33, 34, and then you are in a hurry. Plus, already you have lost so much time, so busy, so stressed out, that there is only weekend sex. Again, you'll not hit the right time. So the baby cannot come out from a printer where both of you are busy in your computers. You need to stop the computer, take your time out and get out and have a good fun, and you will get pregnant. So why woman's age is very important. Remember that when we are born, or rather when we are inside our mother's womb, there is a certain number of eggs that is there, that is generated in our ovary. But when we are born, we are about having 1 million eggs in our basket. We don't keep producing eggs as we age, unlike men who every 3 months produce new set of sperms. We have a basket. God has given us 1 million eggs. Also, by the time you reach puberty, which could be very early these days, like 10 or 11 years, you are left about, say, some 300,000 eggs or 3. Now, from 10 years, you're not going to try your pregnancy in 10 years. By the time you actually come to try at 30 years, 20 years are already gone. With each cycle, you keep declining, you keep declining, you keep declining. So the number of eggs by 30, 35 is very low. Also, the age factor becomes, because after 35, the quality of eggs also go low. You may have more chromosomal abnormalities, some other problems that may take place. That is why people talk about biological clock. And that is why your neighbor or your mother-in-law or your mother is looking at you, that you got married at 32. Now what's happening? Now what's happening? Get pregnant. Because they understand that age matters. So you have to keep all these things into your perspective. When do you meet a gynecologist? If you are married for 1 year, and had sexual intercourse continuously for 1 year without any protection, and you have not got pregnant, it's time to meet a gynecologist. Remember, if you are more than 35 years, but had this unprotected intercourse for 6 months itself and still not got pregnant, don't wait for 1 year. Or if you are more than 40 years, haven't got pregnant or got married recently, but have meet the gynecologist, because age is now not in your favor. Plus, I would also make this small point of make sure that you are having proper sexual intercourse. A lot of young couples come to us today who probably are 3 years in their married life or 2 years in their married life, but still haven't had a proper sexual intercourse. Maybe because of fear of the woman, maybe because of performance pressure, maybe because of ejaculatory disorder, or mainly because just a tight hymen. So make sure that your coitus that is happening is good so that you are able to conceive. So these are very simple things before I come to talk about PCOS or endometriosis or fibroid, where very small percentage of women really have a problem. 70 to 80%, maybe even up to 85% women actually do not have so much problem that we really need to intervene too much. We just need to guide you and counsel you. So what can we do when you come to us? First, I'd talk about PCOS. Now, this is, I think, the focus of your organization, as well as it is something which is rampant. But remember, every woman is not PCOS because they thought or a scan report said PCOS. There is a proper criteria on which we will decide that you are PCOS or not. But remember that if you're not getting your periods regularly, if the periods are not coming on time, you're getting delayed cycles, which obviously gives you an indication that you're not ovulating very well. And that can be a problem because I said, three things you needed. You need a good egg. You're not making eggs. How will you get pregnant? So you need to work on it. Remember that PCOD is a condition of your body. Okay. Now this condition of the body will actually make a difference if you will remember that no medication can cure my endometriosis. I've just put a YouTube link here. I can play it for you, but maybe you can go where we are talking about PCOD and how it can be helpful in pregnancy. Remember these small clips that I'm just putting, I'm not going to play for them because I want you to ask me questions and maybe you can go back and listen to these videos later. But in PCOD, you have to remember you are in charge to control. You are in charge to take care of your PCOD. It is neither me nor your mother or mother-in-law or husband can do anything. If you have PCOD, you have a metabolic disorder. Okay, it is presenting like low hormone or it's presenting like your hair problem or acne, but you have a metabolic disorder. What I mean by that, you are not able to handle the carbohydrate that you are taking, which is causing hormonal problem. Simple funda, reduce the carbohydrate, right? Exercise, reduce your weight, come to a good BMI. So whose court ball is? Your court. So you have to make sure that you are doing all this to control the PCOS and keep it under control. If you are able to reverse the effect of this metabolic error and get regular periods, you start producing eggs and you get pregnant. In case you are not going to, still not producing eggs, I can help you to get eggs. But believe me, those medications don't work very well till you have made an effort and at least lost 5% of it. So remember that PCO is a bilateral problem. You can do something, I can do something. You just don't come and sit in my office and say, do something. I can't, because you have to be receptive to my treatment. Having said about PCODs, we'll take the questions if any of your listeners have any more, but we will now come to what we can treat. Now, what we can treat is not forming good or enough eggs. One reason is anovulation of PCOD. The other problem can be ovarian problems like ovarian cyst, presence of endometriosis, presence of dermoid cyst, or some problem in the ovary which is not letting it form good and enough eggs. So we need to help out with the other hormone test, put in supplements, make sure if there is a cyst, remove the cyst, do the surgery or something that we need to do. If the partner has sperm problems, you need to visit an andrologist or a urologist or the fertility specialist who can either treat and improve the fertility sperm problems, or if the sperm problems are so bad or cannot be treated, then we can do something that is called cleaning of the sperm, or take the right sperms and do an IUI or an IVF or something else that we can do for that. Last comes that happy uterus, the good person, right? They need to be in good health. What can make it into a bad health? What can we treat there? Now I will come to another clip which you can go to YouTube and see what can we improve by how can we improve fertility by surgical management. Now you have to remember that every fertility issue cannot be managed only by a fertility center which does IVF and IUI. that is usually a kind of last resort or a very calculated made decision. My slides are visible, right? Something else came up on the screen. Okay. My slides are visible?
Yes, they are visible.
Okay, great,
We can't see
great.
anything but the slide.
Okay, thank you so much. So we are now talking about what we can treat for how can we improve your fertility surgically. There are many things that we can do. Let's start with simple things. You may have a previous surgery or you may have your tubes engaged. So you need to have the tract free and nice, right? So if the tubes are engaged, there's some blockage in the tube, we can clear on that. You have some tumors in the uterus and ovaries, we can remove that. You have endometriosis, we can treat it surgically. You have tubal blockage or you have a, say, family planning surgery, tubal ligation done, I need to open it, I can do that. You have intrauterine pathology like polyps or fibroids or adhesions, hysteroscopically, I can clear that. So there are many things we can improve. And when we improve surgically, you actually have a beautiful chance of getting pregnant on your own. I have so many patients in which we operate and they come back happily and say, "Ma'am, we are pregnant." I said, "Great, that's what you wanted." So you must give that a chance and understand and discuss with your doctor the problem that you're facing. Is it surgically correctable? You can see this video and we have discussed many of these points here. The second thing that is very common and not looked into very well is a problem of fibroids and fertility. Before I begin what I'm going to tell you to do, you must understand that fibroid and fertility, the nexus, the last word has not been said. Meaning, not all patients of fibroid will have fertility issue. Some patients of fibroid can get pregnant, continue and deliver at 9 months. But some patients of fibroid can have fertility issue. We can remove the fibroid, make the uterus nice and happy, but doesn't guarantee that you will get pregnant, because for pregnancy, you just not need the uterus. You also need good sperms and good ovum. So if your problem was only fibroids, removing will definitely increase your chance of spontaneous pregnancy, as well as if there are other egg and sperm problem, maybe with an IVF IUI. So if there are fibroids, first question you need to ask your doctor, is the fibroid directly causing my infertility? There are certain fibroids that directly cause. They should be able to tell you. Second, removing fibroid, how much benefit will I get? Third, fibroid surgery will also be required if you are symptomatic. That means you are having pain, you are having extra bleeding, you are having some other issue. Then removing fibroid will improve all that. So you have to first ask the question, do I need surgery for my fibroid? Because no fibroid can disappear by any medication. So don't be in that utopian world that I'll take this, I'll take homeopathy, I'll take Ayurvedic. Please, it will not disappear. Either you leave it alone or get it out. It's as simple as that. As of now, what medication and surgical principles we have to do. Second question, if you have a fibroid, how do we remove it? Now today, it is not right to do an open surgery to remove fibroids. Really not right. If your doctor is suggesting that, take a second opinion. I'm sure somebody else will be able to do it by minimal access. What do we mean by minimal access way? By keyhole surgery, which is by colloquial language called as laparoscopic surgery, which is done by many surgeons in this country and are doing very good job. But we also have a new and more advanced technology in laparoscopic surgery, which we call robotic assistance. Now, there is no robot. There is no Chitti, there is no Sai, Ravan or whatever you think of as a robot. It is just a computer assistance that gives me to do the same surgery in a more advanced and precise manner. So both in fibroids and in endometriosis today, if it permits and if the patients agree, we like to offer that because we know we can do much better surgery. If as a layman, I want to tell you what a laparoscopy and what a robot can do, I'll give you an example of the phone. Now, all of us know we had that Nokia phone where we would punch some keys, make a call, take a SMS. Fine, you did your job. But do you have that in your pocket? No, we all have smartphones. For what? Because the same phone, same SMS, it can come with a video. It can come with an image. I can do much more. So that's the difference today. I feel being in the field as a surgeon for almost 25 years, doing laparoscopy for 25 years, doing robotic for 10 years, I know that the robotic equipment gives me a more precision and I can do my surgery like a smartphone, by the way. So if the fibroids are causing you a fertility issue, removing will definitely improve your chances. I'm not going to show you any gory surgery of my video of my surgery because I think even they will switch it off. It's not right to show to general public that. So I'm not put any of those videos. The second is endometriosis, which I think your organization is really smart enough to pick it up because we need to address it in three things. One, why do we want to talk about endometriosis? We need to talk about endometriosis because it is a lifelong chronic problem. Let us for a minute forget fertility. In between, in that life of the woman or girl, the fertility will trouble her for a few years because of endometriosis. But have you ever given the importance to the chronic pain she suffers? For the kind of difficulty she has during her periods? It is literally like those 4 or 5 days of her day, from her month has vanished. She is not capable of doing anything. She can't do, she's intractable pain, lying at home, missing school, missing college, missing work. No woman deserves that. So we need to talk about it. We need to make women understand that this is what it is and this is how you can get help. In between of that endometriosis journey comes fertility. At that time, we know 30% of patients who are having fertility issues may have endometriosis. Now, what do we do with that endometriosis? I'm just going to come back in it in a minute's time. So this is the reason why, because awareness is very important. Why awareness is important? Because the first and the biggest sign or the most common sign of endometriosis is pain in periods. Now, what happens if you're 13 or 14 years and somebody says you have pain in period? Mother or grandmother will say, oh, everybody has it after marriage, it will go away, leave it, leave it. But if you are having pain which is intractable, not letting you go to school and college, you need medication, please see a gynecologist. Because we can give you some things in the nip and nip the problem in the bud so that it does not progress so much by the time you're 30 and you're wanting a pregnancy. It is also missed, not because of this. Some women will have non-specific problems. They will not have dysmenorrhea. With dysmenorrhea, they may have a lot of bloating, gas, rectal pain, difficulty in passing motion. So where do they go? They don't come to gynecologists, they go to gastroenterologists. They'll be treating them for gas for years together. So we know that average women misses 6 years of her life before a diagnosis of endometriosis is made. Not worth it. So remember why we need to talk about fertility. What are the symptoms and signs of fertility, which you can know. Many, you will find many videos. There are many videos by me as well, or you can directly ask questions and we'll answer that for you. What can we do? Once you have advanced endometriosis, we need to do something what we call as endometriosis excision surgery. Why do we need that? We need that for two purposes. One, to relieve you of the pain. Because all those deposits and endometriotic lesions that are formed will continue to give you pain till I remove it. Removing also stabilizes the pelvis, the whole overall thing, and improves your chance of fertility. You may spontaneously get pregnant after I do the surgery, or you may need ART. But remember 3 things when you think of endometriosis surgery. When, where, who. When means when in that life. I told you endometriosis is a long problem. When in that life should I go and endometriosis surgery? 1, if the pain is intractable, nothing is working. 2, if the disease is very advanced. 3, I'm planning a pregnancy but not able to get pregnant. These are the only 3 reasons you should get the surgery. Second, where? Where minimal access surgery is available, where you have all the technologies that is required to do a surgery completely. Who? That's the next question. Make sure you directly ask your doctor, how experienced are you in doing endometriosis surgery? Not all doctors, not all surgeons are experienced. Fair enough. You must search for a center which does the surgery day in, day out, and then you will get it. Because the first surgery has the best result. Don't think, okay, today something will happen. I just had one woman walk into my office who had surgery in the month of November. This is just December. In, out, nothing happened. And now she's at a fix. I can't do a surgery in a month's time. I said, okay, do something for 3 months, then we'll come back. She's losing time. She's already 36. So remember who, when, where, and who. So after I'll just close, I think I've taken my 20 minutes. Last one thing I'll like to talk to you, that forget about the disease. Again, come back to that same positive note of fertility. Why wouldn't you be fertile if you don't have any major problems? Remember, there are 3 or 4 things which you need to take. If you're planning a pregnancy, take good diet. Fresh fruit and vegetables, all color is very important because they all give you different micronutrients. All of them will be very important. Remember to have some sunshine. Cannot be in a closed room the whole day in the office. You have to get out. You need that vitamin D, which is so important for reproduction. And sometimes we also say Chandani Raat. You need some moonlight also in your body to set up your circadian rhythm, which will cause your ovulation well. You need to have the correct BMI between 18 to 24. Look into a BMI calculator. Calculate your BMI. Work on it, because without that, success of pregnancy is also low. You need to cut down your alcohol, caffeine. No type of alcohol or no quantity of alcohol is good when you are planning pregnancy. Maybe both you and your partner should cut it down as much as possible. And of course, no drugs. Exercise and reducing stress is very, very important when you're planning pregnancy because body responds differently. And last but not the least, good sleep. And sleeping at the same time, getting up at the same time is so again important for your biological rhythm. So I'm going to stop now. I hope you will ask questions and we will answer. This is again my greetings from Hyderabad, from our hospital, and it would be lovely to connect with all of you. Thank you so much.
Thank you, Dr. Sinha. That was really, really very informative. And if you will allow me, I will request Dr. Kanodia to make his presentation, and then we can take the
Perfect.
questions.
I am waiting for this.
So, yeah, thank you. So it's my pleasure to introduce Dr. Hemant Kanodia, and he's also an MD and a pelvic endoscopic surgeon. He's a director of Excellence Endocare, I think, and is a practicing exclusive gynec endoscopic surgery surgeon since 2001. He has a special interest in MIS for deep infiltrating endometriosis, pelvic floor repairs, carcinoma, I think it is carcinoma, endometrium, and complex pelvic surgeries. He's a visiting consultant at various corporate hospitals and fertility centers, and an expert honorary visiting consultant at R.N. Cooper Hospital, Mumbai. So without much ado, let us welcome Dr. Kanodia, and he will be talking about endometriosis and infertility. Dr. Kanodia, are you present? Khushbu?
Yes, ma'am. I'll just connect with him and just can we wait for him for 1-2 minutes?
Yeah. Maybe I will ask one question to Dr. Sinha by the time he joins.
Yes, sure.
So Dr. Sinha, you mentioned about robotic surgery and minimal access surgery, and why it is so important to choose a surgeon who is trained on that. One of the biggest challenges that people face is paying for their procedures. So are these kind of surgeries included in any insurance policies? Ma'am, you are on mute.
Sorry, I was just not wanting to disturb Kanodia. Laparoscopy is 100% included now, but the only trick there is the minute the insurance companies understand that we are doing for infertility, they say no.
Okay.
Okay.
Is there a way to get around this?
Yeah, if we are doing these surgeries for pain or bleeding, they will cover. So laparoscopy is 100% cover. Robotic surgery also, nobody can say no today because of the insurance book. But they may a little noise and say, okay, we'll cover this, cover that. You know how insurance companies go. But the challenge, I think, as an organization, you should pick up. Number one, why infertility should not be covered by insurance? Is it not a problem of the woman? And infertility is not just troubling her physically, it is also troubling her mentally. She's paying insurance premium to you. Why you can't cover her, at least the surgery part of infertility? Because that is one time. They may think, okay, going for multiple cycles of IVs, then how do you put a stop after 1 cycle or 2 cycles? I agree. Or they may put it, okay, only 2 cycles will cover. But it's not right to not cover surgical management. Maybe we should start a memorandum on it.
Yeah. No, I completely agree. And we will start something on that. I think we have Dr. Yeah, and okay. we have, I can see Dr. Kanodia, but he disappeared again. So, Dr.
He's a busy man.
Yes, ma'am. He was having some network issue, so he's just rejoining again.
Sure.
Okay. No issues. So maybe I will ask one more question. So Dr. Sinha, you mentioned about how we can assist reproduction through IUI and IVI. So people are usually confused in these two methods. Is there any major difference between the two, and which one would be preferred for a woman depending upon her condition?
Okay. Now, the difference between IUI and IVF is IUI basically means that we are just bypassing the coitus. Okay, we just bypass the sex. So we just, instead of husband putting the sex into the vagina, we collected the sperms and put it inside the uterus. Rest, we are like the same. The eggs have to come, they have to go to the tube, they have to come to the uterus. So rest, we are dependent on the physiology. But as compared to IVF, we actually collect the eggs separately, we collect the sperm separately, we put it in a test tube, we create the embryo, and then put the embryo back in the uterus. So it's a complete artificial technique.
Okay, got it. And which one has a better success rate then?
I wouldn't call anything having better or not good success rate. All depends upon for what indication it has been used, what is the background problem in the woman. So about 30 to 40% is what we expect a success rate in one cycle.
Yeah. Okay, thank you so much. And Dr. Kanoja, can we hear you? Can you hear us? Still connectivity problem? I think he's disappeared again. So I will ask one more question by the time he joins us again. So you have already, there was one question, does being stressed affect the success of any procedure of conception? And you have already asked that question saying you need a happy mind and a happy uterus for the pregnancy to happen. You have also answered the question, or what are my options if my husband's count is less? But I had one follow-up question to this. Usually the woman is the person who is under stress for all checkups, and the husbands don't turn up for a checkup. And even if the count is less, sometimes they don't agree that the problem is with them. So how can organizations like mine, for example, spread awareness on this, that both the couples have to come together, both a husband and the wife or the partners have to be tested, and it's not just one person who is responsible for the conception. So what can be done to raise more awareness on this, because it's also a gender issue? Ma'am, you're on mute again.
Okay. You've made a very valid point, Ratna. This really happens. We
Yeah.
find that women are brought by their mother or mother-in-laws very often, and the husband never. So as a principal, I will never talk to them in detail. I said both have to come. Now, even if I have to guide them what is the right days to have sex, what am I going to tell in my front of mother-in-law that is then you should have sex, right? The husband should be there, right? So that's simple thing. So if I get the husband in my office, then I'm able to get through with him and explain to him, see, 30% problem female problem hai, 30% male problem hai, and 30% unknown problem. So unless I clear these two, I can't go to the unknown. So I have to clear these two. I never start any treatment till the husband's semen report is in front of me. But yes, awareness, a lot of awareness is needed. I'm not very sure how you will create that awareness, because you're probably running a NGO or something. But putting it across by multiple people talking on different forum where men is involved. In fact, I don't know, when you have this Women's and Wings, how many male members you have in your organization. They're probably all women.
Yes,
Correct?
most of them. We did try to include men, but then it is hard to know who is genuine and who is a spammer, because many we do get some invitations for people who are just interested because there are so many women here. So social media has that challenge, that it is hard to know what the purpose of joining the group is. So we try and restrict it to the extent possible. But usually our campaigns include both genders.
I think that's a
where
good idea. I don't know whom you are addressing in your campaigns, but if you are addressing, say, the young upwardly crowd, so you can actually get touch in with most of the organizations where these men are employed.
Yeah.
Okay, because it's not just telling them about the problem, but there are simple things like using laptop. Okay, we teach men not to use laptop really on their lap, because it increases the temperature near their scrotum, and that causes sperm problems. But most men don't understand. So that is something across, maybe you can, that's one point you can get through to them and start talking. The second thing, they don't understand that caffeine, tobacco, alcohol, smoking can cause sperm difficulties. So that's again one area of challenge, because people who smoke a lot may have correct count in their sperms, but may have DNA fragmentation very high. That means they are fragmented DNAs. The sperms are abnormal. Even if the woman is able to get pregnant, she'll have multiple abortions.
Yeah.
Understand? So I think a lot has to be told to the male or the men, which can go a long way in improving the fertility in women.
I completely agree. And I think we have Dr. Kanoja finally. Sir, are you able to hear us?
Yeah. I'm so sorry. I'm extremely sorry about the technical glitch,
problem.
because I am in Surat. I just finished a live surgery around an hour back. And coincidentally, it was a fertility enhancing surgery for endometriosis, which we did now. And it's coincidentally coinciding with the topic almost I'm going to refer to. Hello, madam. Good afternoon, Ruma Sinha, madam. It's nice to see you. And I heard a bit of your talk. Thank you so much for that. So if you want, I can share my screen and start the talk before this Wi-Fi starts behaving in a odd manner again. So I'll go for my sharing
Please.
screen. Okay.
Please do.
So I think now screen broadcast. Yeah, just give me a moment till I come onto my screen. And before that, I'll just stop my video. Yeah, device. Can you see my screen now? Is
Yes,
my
we see
screen
your
visible,
desktop.
please?
Yeah, I
okay,
can
fine.
see your
So
desktop. Yeah,
I'll just start my presentation. Now you can see my slides.
I can.
Yeah. So this is on fertility aspects. So the fertility aspect which I specialize in is mainly endometriosis, the surgical aspect, and I'll be talking mainly on that. I hope my audio is quite audible and it's fine. Just before I proceed.
Yeah, it's perfect.
Thank you so much. So if you can see over here, this endometriosis, the slides, these are the slides. I'm also not going to show any gory videos, as madam said. So you can see how much endometriosis can affect the pelvis. It can really cause chaos in the pelvis. And endometriosis is quite rampant. And in the last 10, 15 years, we have seen an exponential increase in the incidence of endometriosis, even in young age group, even in the adolescent age group. It was normally considered a problem in the reproductive age group after marriage, but now you're seeing so many young females affected with this problem. So the problem boils down to what is endometriosis. It is very ill understood amongst patients, amongst the common people, and even it is sort of ill understood among specialists also, because endometriosis is a very enigmatic disease. And that's why nowadays we have specialists in endometriosis who deal with this in special interest or with focus on endometriosis. And that's why they are well tuned to picking up endometriosis and managing it well. So endometriosis is nothing but it is the endometrial lining or the endometrial tissue or endometrial like tissue which is present outside the uterus. So let me explain to you in a very simple manner diagrammatically. So if you see here, this is the uterus. This is the mouth of the uterus, also known as the cervix, which opens into the vagina. And if I have to show the endometrium, this is the normal lining of the endometrium over here. You can see in red. Okay. And if you see, the uterus is surrounded by different organs. In the anteriorly or in the front is the bladder over here. Okay. That's the bladder, urinary bladder. From here, the urine drains out. Okay. And here posteriorly is the rectum and the sigmoid colon. So as I told you, by definition, endometriosis is nothing. I hope my slide is visible and whatever I'm drawing, sketching is visible to the audience.
Yes, it is. And I'm quite amazed.
Thank you so
how
much.
It is being
Yeah. So this endometrial lining, the one which you're seeing in red, it is supposed to be present over here only within the uterus, which is a potential cavity. Every month, in response to the hormones, cyclically, the endometrium sheds off. If there is no pregnancy, there is bleeding over here every month, according to your cycle. Now, what happens in endometriosis, this lining, which is supposed to be present here and only here, is present outside within the abdomen, outside the uterus, within the abdomen. So it could be here behind the cervix, it could be on the bowel, it could be on the bladder, and on the peritoneum, that is the lining within the abdomen, or it could be present within the uterine wall also, where it is not supposed to be present, a condition known as adenomyosis. So endometriosis and adenomyosis are the same thing. Adenomyosis is nothing but endometriosis of the musculature of the uterus. So you can see these implants are present over here. And as I have made them bright red over here, they are so inflammatory and bright red inside also. By that, I mean it is a chronic inflammatory process which is going on. Now, as this endometrium responds to the hormone cyclically, even this ectopic endometrium, or which is outside, placed outside, responds to hormone cyclically, and there is microbleeding inside. at least this bleeding has an outlet. This bleeding, microbleeding, has no outlet, and it collects over there. Because of this, there's a reaction, there's release of oxygen-free radicals, and everything gets stuck to each other. And that's why there is complete havoc inside. There is change in the normal milieu of the pelvis, and there is a lot of adhesions, or the tissues get stuck to each other. Now, if I show you in another view, okay, suppose this is the uterus. This is another view of the uterus. Okay, this is the uterus. It has two tubes attached to it. Okay, this is left and right tube. Similarly, there are two ovaries, left and right ovary. This is the entire uterus body, and these are the ligaments which support the uterus. And as I told you, posteriorly is the sigmoid, large intestine, and the rectum, and anteriorly you have the bladder. So that was a different angle we viewed in, and this is a different angle. So just to make you aware, maybe this is the left side as we see it on endoscope, and this is the right side. So similarly, as I told you, this ectopic tissue of endometrium can be present over here, infiltrating into the bowel. It can be present on these ligaments, onto the peritoneum, which is lining the abdomen and the pelvis, into the ovary. When it is present in the ovary, it is known as a condition as endometrioma. Okay, it can be present on the tube or within the tube where there is collection of blood known as hematosalpinx. It can be present on the bladder, and as I told you, within the wall of the uterus in the form of adenomyosis. Now, what it does when it is present in the ovary over here, it really causes, again, chronic inflammatory reaction and damages the ovarian reserve. By this I mean that the ovary already has a reserve of eggs inside. Okay, and this chronic inflammatory process reduces this reserve further. Okay, and that's why there is a problem in ovulation and there is a problem in conceiving. To explain to you in simple terms how fertility takes place, an egg is ready every month as a dominant follicle. This gets released, this goes into the tube, the sperms come from below, the fertilization actually takes place in the tube, and then this fertilized ovum gets migrated into the uterus and gets implanted over there to rest for 9 months till delivery and grows over there, obviously. So if you see, these are all the problems associated with endometriosis. So anything which causes chronic inflammation in the pelvis is definitely going to cause adhesions. So what are the risk factors for this? Anything which prevents the female from getting pregnant for a long time. In the sense, what happens when there is a pregnancy, there is a pseudo menopause. All the hormones are suppressed for those 9 months. Okay, so patients who don't get pregnant, like nulli gravidas, who don't get pregnant or who get pregnant later in life, early menarche means they are exposed to repeated menses for a longer period of time. Late menopause, again, the same logic holds true. Short menstrual cycles or frequent cycles, heavy menstrual periods that last longer than 7 days, we call it as menorrhagia, and having higher levels of estrogen in the body. So these are estrogen dependent tumors. They are not only dependent or respond to the estrogen from within the bodies, this tissue has its autologous or own autonomous estrogen production. They produce estrogen on their own and are self-propagating cells which have clonicity and keep on duplicating. Now, you'll ask me the other question is this cancer? No, this is not cancer, because when in cancer, the cells grow at an exponential rate, that is true, but they spread to further organs, or there is metastasis. Here, it is a kind of local metastasis, that is, they are invading into the tissues around the uterus, like the bowel, the bladder, the tubes, and so on and so forth. Then low body mass index is also a risk factor. Then relatives, yes, it has a genetic component also. Also, there's an element of epigenetic, where a person might be having the genes, or there might be a mutation in the gene, which is, probably happening due to some environmental factor or lifestyle change factor, which triggers this evolution. And some disorders of the reproductive tract, where there's obstruction to the menstrual blood flow. This menstrual blood flow can go back into the peritoneal cavity and can cause the same kind of adhesion. So there are various theories. The initial theory was that it is because of retrograde menstruation. So if I go back to this diagram, the menstruation happens from the uterus, okay, and there is some amount which goes through this open tube into the abdomen or the peritoneal cavity, and those endometrial cells, it is believed, can get entrapped into the peritoneal cavity and grow. But this theory has been debunked a long back and doesn't hold really true now. So it's more of a postulation or a hypothesis, but doesn't really hold true. Other thing is that transformation of the peritoneal cells. There is the peritoneum which is lining the abdominal cavity, and these cells can get transformed on their own into endometrium kind of cells, which further grow and cause endometriosis. Another interesting theory, which really holds some substance, is that this transformation takes place in the embryonic stage itself. These cells, they migrate and they stay silent till the female reaches puberty and start responding to the hormones. There can be surgical scar implantation of the endometriosis also, like after cesarean, where the uterus is opened. So some of the endometrium cells can escape into the peritoneal cavity or into the scar where the incision is taken, and this leads to surgical scar implantation or scar endometriosis. Also, endometrial cells can be transported through the lymphatics to other parts of the body, and this has definitely an immune component, if you see, and it is quite well related with chronic disorders like inflammatory bowel syndrome and ankylosing spondylitis, these kind of things. So the sites of endometriosis. So if I go to this diagram again, if I show you, the commonest site is the ovaries, then there is the region of the bladder, then the ligaments which I showed you, also the posterior part of the uterus, and the other ligaments associated around the uterus. There can be pelvic and extrapelvic endometriosis also. By extrapelvic, the pelvic brim is still the sacral bone or the last vertebra, the lumbar vertebra which you see. But the endometriosis can go above the pelvis, also higher up into the organs like the small intestine, into the diaphragm, onto the liver, and it has been documented in the brain too. So it's really kind of a debilitating and enigmatic disease. Pelvic endometriosis is mainly of three types. That is the peritoneal covering. In the ovary, I showed you the endometrioma. The peritoneal can be of two types. It is superficial peritoneal and the deep infiltrating, which is mainly invading into the surrounding organs. The extrapelvic endometriosis can be in the gastrointestinal tract, as I told you, urinary tract, scar endometriosis. The vagina also can have evidence of endometriosis, and thoracic endometriosis. Now the question is, how do we pick up this ailment? Okay, the main thing what these patients will present is with pain. Most of the times they present with pain. Coincidentally, it can get diagnosed with infertility because 40% of the infertile patients will have some sort of endometriosis. And endometriosis, patients having endometriosis, out of them 50% will have infertility. So the correlation is quite clear because of the chronic inflammation and the distortion of the organs, whereby the multifactorial things which cause pregnancy, like the tubal motility, the release of the egg, the fertilization, implantation, all these factors at some point get affected by endometriosis. So normally, on an average, it takes around 7 to 8 years for this condition to be diagnosed from where the time it starts or from the time of inception. So it can be some sort of a silent killer. Actually, it just grows inside without any manifestation in the beginning stage, and that's why one needs to be alert about this disease, because by the time it's diagnosed, it's really in an advanced stage whereby the management becomes even more complex for the managing doctor or the surgeon. So I always tell the general gynecologist and the general practitioners, do not neglect the symptom of dysmenorrhea in your patients. Normally, it is taken very lightly, and the normal myth and norm is that the pain of menses is a routine thing. Yes, it is a routine thing, and almost every female is going to suffer from it. But there is a way to grade the pain. We have a visual analog score over here. And if this visual analog score points towards debilitating pain, please remember that word, debilitating pain, it points to the fact that it has to be investigated further. There cannot be, any negligence towards these symptoms. And there is a special term coined for this by the medical fraternity known as gaslighting. That is belittling the symptoms of the patient or associating it with some psychosomatic problem or neurological problem, which is really not matching up with her findings. So don't take it lightly, especially if you find young girls who are going to college, and if they are missing college or they're missing productive time of their life by resting at home due to this debilitating pain, it really needs to be investigated on a war footing, because this could be endometriosis. And that is how most of these cases get missed out, and they later on manifest with a lot of pain, infertility. I have seen so many patients who have been suicidal with this pain. It can get so debilitating. Now, this is not to create a fear factor in your brain that every pain or every dysmenorrhea is endometriosis, but what is required is to keep it at the back of your mind that there could be a possibility, and not to just sit upon these symptoms, maintain a pain score diary, and if it is chronically paining or the level is high, then it needs to be surely investigated. Now, the question arises is, how do you investigate this? There are various modalities of investigation. The gold standard was at a particular time laparoscopy, that is seeing with the telescope inside through a camera system on a screen and documenting endometriosis. But nowadays the imaging systems are very nice. So you have something, as you all know, the ultrasound. A good ultrasound can pick up good signs of endometriosis. If there is a suspicion, one can progress with MRI, which is even better in terms of sensitivity and specificity in picking up the problem. Now, the issue is, how do we manage this disease? I'll just interrupt over here. Please let me know when my time is up. I might just continue talking. Is that okay?
Yeah, no problem.
Hello.
It is very interesting. Please go ahead.
Yeah. How much time have we already finished? I think 10-15 minutes already done.
Yeah, we have some time. So we have another half an hour, including the Q&A. So please go ahead.
Okay, so the ultrasound and the MRI are the modalities of investigation. Now, obviously, this pain is going to respond to painkillers, but you cannot take painkillers lifelong. There is only up to a certain limit without side effects that you can take painkillers. Now, there are two types how to manage this patient. Again, coming to the diagnosis, as I told you, if everything is clear and still the pain is there, do not hesitate when your doctor suggests you for a laparoscopy. You might feel everything is normal. Why do I need a laparoscopy to see inside to make a diagnosis? Sometimes subtle findings of endometriosis may not be picked up even on the best of imaging, which can be only picked up under vision on laparoscopy. So laparoscopy, again, even in this age, is the gold standard for diagnosis and even a gold standard for management. So just a minute, okay? I'll just take out this screen. Yeah. So the problem with endometriosis, why is it an enigmatic disease? It is an enigmatic disease because sometimes the symptoms and the findings do not match each other. So endometriosis is graded into different grades. That is grade 1 to 4. Okay. Sometimes a grade 1, if you see clinically, might be having severe symptoms. Okay. And if you see the findings, there will be, just grade 1, minimal adhesions, but the symptoms are severe. Then you will have grade 4. So many times in an infertility patient, when we are evaluating and when we have done a scopy, the patient, doesn't have any pain. She's absolutely asymptomatic. And there you will see, grade 4 endometriosis, but maybe no symptoms. And that's why this disease is really enigmatic, because the symptoms and the findings many a times do not match up to each other, and that is why it becomes sometimes more difficult to take a few clinical decisions, whether we need to be so radical with the surgery or we need to really tone down our surgery. So the most important deciding factor for the patient's management, I would say, is the symptoms. Okay, now what are the commonest symptoms that you see? So you can have, as I told you, dysmenorrhea, that is extremely painful periods, dyspareunia, that is painful intercourse, then dyschezia, that is painful passage of stools when the endometriotic tissue is infiltrating into the rectum or the sigmoid, then dysuria, that is painful urination when there's involvement of the bladder, and chronic lower abdominal pain. Okay, sometimes there can be lower backache also, and pain radiating up to the thigh and the lower limb when the major nerves of the lower limb are involved, like the sciatic nerve. So this I told you about the symptoms. The other thing the patient will present with is infertility, and this is one goal you need to keep in mind while treating the patient, whether she wants a kid or whether she's already finished with her childbearing. Sometimes we see, females have had their childbearing, they've had 2 or 3 kids, no problem in having kids, everything went off smooth, no history of infertility, and probably they have come up later with endometriosis where we need to remove the uterus. Now, let me tell you one thing also. Sometimes we have had to remove the uterus of even young females. This is the only disease where, we probably think of removing at a younger age, say between 30, 34, when we absolutely try and avoid hysterectomy. But the affliction and the disease is so much that sometimes we have no other choice. Even infertility patients, they come and demand a hysterectomy because they say, we don't want a child, we just want to get rid of this ailment and the pain, because it is so debilitating. It is absolutely, causing chaos in our life. So that's why the goal of the patient, the symptoms, the desire for pregnancy, it's all which matters. So for dealing or managing these patients, so there's no fixed formula which fits all. The treatment in these cases has to be customized. And the problem with this disease is that there is involvement of the surrounding tissue, as I showed you over here in this diagram. Yeah, there's involvement of the rectum, the bladder. So sometimes you have to, operate on these structures also if there is an involvement. The patient will present with, disturbed bowel habits like constipation, occlusive symptoms of stool where there is pain during passage of stools. So that means, suppose if this is the bowel lumen. Okay, let me show you in another color. So this is the bowel lumen over here, and that's the endometriotic implant over here. It could be a small implant just superficially, it could be which is involving up to the muscle layer, or it could be through and through reaching the inner lining of the bowel and involving a good big circumference of the bowel. Now, depending on how much the involvement is, there can be either just removal of this tissue or removal of part of that intestine and restapling it in order to relieve the patient of the symptoms. The similar happens with the bladder and the ureter. One affection which I forgot to mention is the ureter. I'm so sorry about that because I just remembered. So there are the ureters running over here from 2 sides which carry urine from the kidney up to the bladder over here anteriorly. So this ureter also can get entangled by endometriosis. This also can get entangled by endometriosis and can have problems. In many cases, we have seen that there is silent death of the kidney because of the obstruction of the ureter, which was never picked up in the initial stages, which caused problem into the kidney because of improper drainage of urine. So what we exercise normally is something known as economic radicalism. So in these surgeries, sometimes you need to have a radical approach where you need to cut a lot of things or sacrifice a lot of things. But since this is not cancer, we do not want to give excessive morbidity to the patient. So that's why a term is being coined called as economic radicalism, whereas we are being radical towards the disease, but economic towards the function of organs. Because if I try removing everything, the nerves also will get damaged. There will be lifelong problem in passage of stools and in the frequency and passage of urine. So we have to really balance it out, and that's why there are very few specialists who are dealing and dedicated towards endometriosis. So what does one need to look as a patient in your doctor when you need some intervention for endometriosis? First of all, endometriosis is a specialty by itself. Okay, it cannot be managed at least surgically by each and every gynecologist. It is to be managed by people who have special focus and interest on the disease, who have been managing it for quite a period of time, and who deal with this disease on almost a routine basis. So these are known as endometriosis excision specialists. So search for a doctor who is specialized in this kind of surgery, so your result will be quite optimum. There is a medical role to management of this disease also. In fact, it is the first step. I, being a hardcore surgeon, we do not operate on all the patients. We do try medical line of treatment, but it has severe limitations depending upon the severity of the disease and the involvement of the organs. Because if you're going to have this fibrotic tissue over here, the medicine hardly reaches over here. And this fibrotic, by fibrotic tissue, I mean the area is just thickened, all the nerves get entrapped inside, and there is severe pain. There is chronic inflammatory process and inflammatory substances that are being released, which cause that pain and vascular congestion too. So you really need to excise all that disease. Now, will the last question, I think, on the mind of everyone as a common man, is this disease completely curable? The answer is no, 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 no. Because this is something similar to, say, diabetes, where it can be controlled, but it can't be completely eradicated from your body. Yes, but what is required is optimum debulking of the disease. That is, whatever are these visible implants, what you can see on the laparoscope. And why laparoscope? Because laparoscope offers you that kind of magnification to see the disease better rather than doing an open surgery. So it gives you better access to these hidden areas of the pelvis, and the optimum debulking of the disease can be carried out much better in that laparoscopic magnification. Nowadays, we are using the 3D system in laparoscopy, which gives us better view, and the robotic, which Ruma madam also mentioned, which definitely has a better magnification, better precision. So what we do is optimum debulking of the disease. It reduces the load of the inflammation and the load of the disease. However, there is microscopic disease which can recur in the future, but the chances of recurrence are not that high if the first surgery done is optimum in the right hands at the right time. And that's why you need to choose your specialist for endometriosis surgery very wisely. Okay, because once you do an incomplete job, we do a lot of redo cases. The case I operate today live in the workshop is a redo case. Somebody tried to operate her, they couldn't do an optimum job, and she had come to us again today. We had to operate her on her in the workshop. So that's what I'm trying to tell you. So choose wisely your surgeons. There are many good surgeons all over India who are doing endometriosis work, but not all of them. So please, not all gynecologists are endometriosis excision surgeons. So please pick and choose your surgeon wisely after seeing their background, the kind of work they are doing, the kind of experience they have in this field. I think I have covered up. Otherwise, I can just keep on going on this. I'm very passionate about this topic. So I think I'll stop over here, and we'll take some questions. I hope I was clear in explaining the terms, and the message has really gone forth to the common ladies and common people who are hearing this. Thank you so much.
Thank you. Thank you. Thank you, Dr. Kanogia. So I have one question for both of you, and then a couple of questions for each one of you. So both of you have highlighted the fact that there is a 7 to 8 year delay in diagnosis, and that actually compounds the problem, because then it becomes even more difficult to manage. So how can we reduce this this delay in diagnosis, because many patients who come to us go to multiple doctors before they actually have a confirmed diagnosis. How can we
True.
educate common man and people so that they go to the right doctors? I know you said go to the right doctor, but if I'm a person,
It's
in a small city, how do I find the right doctor?
it's actually a very difficult question to answer. So sometimes we think along with the patients, creating awareness in the patient, we need to create more awareness amongst our colleagues, actually, the general gynecologist, who think that a magic pill, there's some medical management, they think it can be given to all patients, it can be given for 2 to 3 years. So we have a patient coming with a big fat file with pain still persisting, and you have to at certain stage stop the medicine and the pain comes back. So it's a very difficult question to answer how it can be picked up. But if you are taking care of the red flags which I mentioned, the warning signs, the alert signs, I think the diagnosis, and now in the last 10 years I've seen the diagnosis has definitely improved. Even our radiologists who are previously not tuned to picking up these problems, now we sit with them and clinically correlate. I show them the video images and then they go back to their radiological images. So the sensitivity of picking up on ultrasound and on MRI has definitely increased, and it's much better than probably what it was, say, 10 years back. Ruma madam's comments, please.
Hi, Hemant. Lovely talk. I think you've given a
Thank
very
you so much.
detailed information about endometriosis. That's good. People need to know. Awareness, awareness, and awareness. First thing. Talk about it, talk about it, talk about it. Because unless we do these two things, women and the general public will not know that there's something going on for these symptoms, which can either be just shrugged off, saying it's a part of growing up, like a dysmenorrhea, or the other non-specific symptom, which they will be roaming around to all other specialties. So with Hemant, I will agree that yes, awareness in public is important, but awareness in our physician colleagues, with our gastroenterology colleagues, other than our gynae and obstetrics colleagues, is also very important for them to understand that if women are coming with these vague problems, they need to ask only one question. Does all this problem exaggerate around the time of the periods? My gastroenterologist just has to ask this question and send the patient to gynecologist to evaluate. That's all. It's as simple, actually.
I agree. There has to be a good referral mechanism. So
And
one
I
question
think that's why, I and madam are over here to create that kind of an awareness. We need to, and we need support groups like you, who are supporting this cause. It's really appreciable. I'm associated with a certain groups in UK also, and all this really helps in creating that kind of an awareness, I think. So I think it's a partnership kind of a thing, where the general public and the medicos, they join together, because we can't do this alone as doctors. We need support of the common people themselves to create awareness. Yes, madam, you were saying something.
Absolutely. No, so my question was for Dr. Sinha. So there is one patient who asked a question saying that she was advised by her doctor to preserve her eggs because she was elderly and when she reached for her fertility treatment, and she wanted to know what this means. Does it mean that more than one egg is removed and it is kept somewhere, and what will happen to those eggs that are preserved?
Okay, this is something which we are now commonly talking to women about it, because I mentioned in my talk that there is also something like a biological clock, and we would like to have good and healthy eggs before the age of 35. So the women are delaying their childbearing for whatever reason it may be. There is a definite indication in a talk about freezing your eggs. Now, what we do is that, say at 32, you decide, okay, for 4 years, I'm not getting married. And once I get married, another 2 years, I want to wait. So you're close to 40 when you will be planning a pregnancy. So you can freeze your eggs in kind of suspended time, that the eggs were good at the age of 32, get those eggs out. And the fertility centers have a system of labeling your eggs and freezing them in very minus degrees so they remain viable. But you cannot have spontaneous pregnancy with those eggs. Then you have to take those eggs out, take the sperm, do an IVF and have a baby. The other way of doing it, for some people who are married and they know their partner, then you can also freeze your embryos, which is a better option than freezing eggs, because they are better viable for frozen embryo transfer. But freezing eggs is becoming, I wouldn't say vogue, but maybe requirement of the social environment that we are in. You can actually freeze yourself in time. That my egg is 32-year-old, even if I'm 40. Understood?
Is that a good thing?
Good and bad both.
Yeah.
It's not just the eggs. At 40, if the woman wants to get pregnant, like we and Hemant are focusing on fertility, and endometriosis and ovum and all that. But the older you get, you have other problems when you get pregnant. So
As
you
well.
may develop hypertension, you may develop diabetes, you may develop other complications. So actually, the right time to give birth or to have pregnancy in a woman's life is, I would say, in a decade of, say, from 25 to 35. But for whatever reason you are not able to do that, you can freeze your eggs in time, but you will still be 40 when you get pregnant, right?
Yeah. Okay, thank
So
you so much.
good or bad, I think I'll leave for the public to decide. I cannot make this judgment call on anyone.
Absolutely.
Medically, it is not advised. We can say that.
See, it's not everything about medicine. It's about social, right?
Yeah.
You may not
Yeah.
find the right partner till you are 36. What will you do?
True, true.
Correct?
Sometimes many things are like demand versus supply kind of a thing also, So
Yeah.
madam knows that better. So it's like that.
So, Dr. Kanoja, you mentioned about depletion of eggs because of chronic inflammation. So there are a few patients who come to us who have had repeated surgeries, and their doctors also tell them that repeated surgeries also lead to depletion, especially if it is
Absolutely.
a chocolate cyst. And therefore, sometimes even if there is a cyst that is growing, they will try and manage it medically, even though there is a lot of pain. So what would be the advice to such women who have not had a child yet, who have a lot of pain and have repeating chocolate cysts or multiple chocolate cysts?
See, there is a size cutoff, okay, which we follow, and which there are international guidelines also, say 3 to 4 centimeters, up to 3 to 4 centimeters, where you can do a pickup if the patient is asymptomatic. If a pickup is possible, then if it's not coming in way of that egg retrieval, you can, either keep her on medical treatment or not do anything about it. But once pain sets in, and that too debilitating pain, it is better to do surgery. And as I told you, the first surgery should be the best shot at endometriosis as far as possible, because I think it should be the only shot, because repeated surgeries are actually contraindicated if the patient is asymptomatic, and not advised, because they can severely deplete the egg reserve further. And that's why I say choose your surgeon wisely for the first surgery, because it is very well documented that if the first surgery has been done optimally, the chances, we have had endometriosis patients, severe grade 4, who have conceived on their own after surgery. They have not required, and I'm sure Ruma madam also will agree with this, you have not required any form of intervention. In fact, we advise them for IVF, but for financial reasons, probably they're waiting for 6-7 months, and they come back with a positive urine pregnancy test. This has happened many times. So you sort of restore the pelvic environment to near normal. Many of them conceive normally also, or they are better responsive to IVF or things like intrauterine insemination. The result is better. So do the first surgery in the right way. Your chances of having recurrence are also less, and chances of a positive result are also higher.
So one patient asks, I have grade 4 bowel endometriosis with adenomyosis and hydrosalpinx. Tried my luck with 1 IUI and 2 IVF, but no luck. Can I still conceive?
I would never say no to any patient that you can't conceive. As I said, I don't like to use the word infertility. Fertility is always the one that we need to use. But we have to assess each patient individually. Now, what are the factors that are not? Having a combination of endometriosis, adenomyosis, hydrosalpinx is a complex combination that she has. If she has not had a surgery with a failure of IUI, IVF, I would suggest have the pelvic anatomy restored. If an adenomyomectomy is possible, we'll do that. Remove that hydrosalpinx, and then see either with the other tube, which is good, she may spontaneously conceive, or this is the patient who will now benefit with an IUI or IVF, whichever thing that the fertility specialist is thinking is best. So I think we have to take it in like individual patient wise. It's not a hard and fast rule that okay, I will do surgery, you'll definitely conceive. I don't do surgery, go for IVF, you'll definitely conceive. It just doesn't work that.
Yeah, so it
So
has
as
to
I
be
told you,
customized as
there's
per the patient.
as I told you, there's not a one shoes that fits all. It's not a fixed formula for this patient. If she has occlusive bowel disease and other things, as you said, severe grade, she must be definitely having pain. Think about the patient. Fertility is just one aspect of it. Have a holistic approach to the patient. She's suffering. You're bothered about the pregnancy. Look at that. A baby will come later. Now at least think about a pain status. At least relieve her of that. So even if the bowel will not affect the fertility aspect, it will at least, reduce, improve the quality of her life. And if
Right.
she's had
Yeah.
previous failed IVF and previous ART attempts are failed, that is definitely an indication for surgery.
They
Thank
need
you.
to
And
reclaim their life.
true, true. So there is
And
one
that
question
is what
which,
our aim is, that is what our aim is, to
Yes.
improve the quality of life of these patients. See, even if my patient comes with a pain score of 10 on 10 or 9 on 10, if she comes back to me after surgery with pain score of 1 or 2 on 10, I'm very happy. My work is done. Okay.
true, true. So there is one question, how many cycles can a person try before giving up for IUI or IVF?
We have a standard,
Madam's question.
we have a standard thought process in that. Especially before you even come for IUI, IVF, we find a lot of patients with ovulation induction drugs, right? The one that we are given for 5 days to produce your super ovulation. They also say that don't try for more than 6 months because you're unnecessarily straining your ovaries. So most of these cycles, not more than 6.
Thank you. And one of the advices that is given by people who are not well trained to manage endometriosis is get pregnant and your endometriosis goes away. And this comes repeatedly from patients. So Dr. Kanoja, what is your advice for this? Because
No,
sometimes they
sorry,
think
I just got
it is
an
a magic
alert
pill.
on my mobile. I just lost what you were saying. Could you just come again, please? I'm so sorry.
So many of our patients come back to us saying that when they went to the doctor with pain and endometriosis, they were advised to get pregnant and that would cure the endometriosis.
No. That's a very, very, very wrong advice. Okay. See, sometimes these patients have severe dyspareunia, and you don't need to be a rocket scientist to realize that relieving the dyspareunia itself by operating is going to definitely, make her chances of natural conception higher. In fact, it's going to make the process of pregnancy even more pleasurable for her and pleasant for her, in fact, if you remove the dyspareunia. So please get away with this myth. These are people who, normally don't favor surgery or don't know how to operate. I'm being frank on this because we have seen such
Yeah.
big fat files and we feel bad for these patients, that they have been just batted here and there. So if she has pain, I feel the most important factor in endometriosis, the most important factor in endometriosis should be symptoms. It should be a symptom-centric approach to patients of endometriosis. That's the bottom line.
I agree with Hemant a bit on this. Yes, pain and management of endometriosis is definitely a lot said by surgical. Okay, but a word of caution. That means you are 22, not yet married. You have dyspareunia, I don't know you have or not, but dyspareunia. And your cysts are about 2 to 3 centimeters. Not a right time to get off. There is a role of medical management and you must try medical management at that point of time. Why? Because
True.
Why? Because the timing of the surgery is also important for your fertility. Because that is, see, for women, pain is fine, but fertility is something that will trouble her the lifelong. Right? She has to answer to herself, answer to her society, everything is there. So if you have endometriosis, which you are not sure whether the surgery is needed now, get it done before you are ready for fertility. Your chance of after surgery spontaneous conception goes deep. Pain will definitely improve. But in that point, if you have dyschezia, now we have unmarried women, girls coming in with severe rectal pain. There is bowel and we have to operate. I can't tell her get married and then I will operate. So you have to take each patient at a time. So timing of surgery, for what are we doing? What is a symptom and what is a desire? Hemant said he will manage symptomatic. I will also think about her desire. What does he want right now? She wants only pain control. I'll manage her to the best of my ability. She wants pain with fertility. We'll manage to the best of our ability. So a combination of surgery, but all medicines that control endometriosis are anti-pregnancy. So the patient comes to me with pain, says, I don't want surgery. I just want fertility. Get my pain. I say, I can't do it. If I control your pain, it will be anti-pregnancy. So either you get surgery done, get your pain cleared, then have the surgery. So there is so many nuances to management of pregnancy. It's a chronic disorder right from the time adolescent, maybe early 20s to 50s, postmenopausal. Every time patient walks in and you suspect endometriosis, I ask 2 questions. What is your symptom that you want me to relieve you with? What is your desire in your life at this point of time? And I will tailor your surgery. That's right. So medicines are there that can control pain and endometriosis. So don't think that surgery is only the answer. We are doing surgery right, left, and center. But both Hemant and I are in referral center. Patients come with grade 4 endometriosis, इधर उधर पिंक
True,
बॉक्स
true,
हमारे
true,
पास आते हैं.
true,
हमारे theatre में
true.
रोज endometriosis होता है. But that does not mean that every endometriosis patient requires Hemant or Uma. Okay.
Perfect, perfect. Madam actually nailed the situation perfectly well. What she said, it has to be customized. And as you say that we are referral centers, so we see patients who have already ran from pillar to pillar and, you know, have come to us as a last resort. So then, as I told you, it's the circumstances, it's the condition, it's, you know, what the patient is going through. It's like you really need to customize and tailor it according to the patient's need and symptoms. I totally agree on that.
Okay, one last question. We know that endometriosis runs in families, meaning more than one person in a family might have it. And there is also this common misconception that twins or multiple pregnancies also run in families. So there is this misconception also that infertility might also be running in families. Is it true?
The causes of infertility might run through the family, not infertility as such. So if a lady has endometriosis, a daughter can have endometriosis, she can land up with infertility. So if by that logic, it's not the infertility which is running genetically, it's the condition which is causing infertility is running genetically. That's what I think.
Yeah, so these are all myths that that
I
exist.
wouldn't say myth. See, there is no myth.
Yeah.
There has to be a logic behind the myth, right? A
Yeah.
PCOD hai. There's a connection to diabetes. So the parent or mother did not have infertility but has severe diabetes. Now the same metabolic disorder is in the daughter. Daughter is having anovulation, getting into infertility. So like, you know, like, of course your genes are matters, but you can make your genes, your environment better by a healthy lifestyle.
Yeah.
Great.
And that
So
is very
any
important
disease,
in
whether it's endometriosis, fertility issues, a fibroid, whatever it is, always look at the larger picture. Look at the woman. Tell her that her lifestyle management, weight management, diet management, eating fresh fruits, vegetables, whatever is very, very important for our life. Forget about the fertility for a minute. Zindagi bhar, it will be good if you are in good lifestyle.
I totally agree
That's
with
the job
Madam.
of a doctor to tell.
I totally agree with Madam, because this requires a holistic approach. You cannot just compartmentalize and say, you know, this is it. But you need to have a holistic approach. That's why in endometriosis, pain management, you know, cognitive behavioral therapy, relaxation, yoga, all these are complementary therapies, not mainstay therapy. Sometimes they are projected as diet for endometriosis, but diet will never cure endometriosis. It's just ancillary and complementary. Okay. So that's what I'm trying to say.
Okay, there is one question which I don't really understand, even though I'm a doctor. So I'm going to read it. Have been identified with endometriosis along with bilateral cyst when I planned to conceive and was having few symptoms of this disease. My AMH level came out to be 6.49. Just wanted to know, is that really bad for conceiving? Do I have any hope or chances?
AMH is very good. So that means she must be producing good eggs. How big are the cysts? So if the endometriosis is very early in this patient with AMH is good and she has not, and she's 1 or 2 months in her trial of pregnancy, I would say, okay, give yourself 3 to 4 months. And if you continue spontaneously, it's well and good. If not, we can clear the endometriosis, make the pelvic better. Chance of spontaneous pregnancy very good. So she's very lucky to have good AMH. She's lucky.
Absolutely. She's fortunate with endometriosis. If she has 6, I think
so maybe
she can actually donate eggs actually with 6. Just joking, but then she has good reserve, what I'm trying to say.
Yeah, and I think this question is answered, but I'll still read it for the benefit of the person who's asked. What should an endometriosis patient do to enhance natural conception and avoid miscarriage? My excision surgery has been done. Left fallopian tube has been taken out as it was damaged. Both ovaries, right tube and uterus are in good condition. So I'm not sure why she's asking about miscarriage, but is miscarriage common for patients who have had surgeries for endometriosis?
Yes, not endometriosis per se. I told you alters the entire milieu inside the pelvis. Okay, it reduces. I mean, it produces a lot of oxygen-free radicals, all that thing, you know, which cause inflammation. So it is seen that in endometriosis, the chances of implantation are reduced. I don't know if it's that directly meaning miscarriage, but definitely implantation. The per se, the first implantation of pregnancy. Miscarriage happens after implantation. Okay, but definitely implantation is affected, but I'm not sure whether miscarriage and endometriosis are directly correlated because I don't do much of obstetrics, but Madam would be a better person to answer that.
Well, I don't do obstetrics at all, Hemant,
Oh,
but that's beside the point. We have the knowledge, so I can tell.
no, I
Yes,
thought something later, so
endometrial.
that's why I got.
I can't do everything. I can only do my surgery well. I can't do often.
Fair enough. Fair
I have
enough.
my team who does that. But anyway,
Yeah.
see, recurrent pregnancy loss or miscarriage is a different chapter in itself. We cannot
True.
just blame endometriosis or one disease for it. There are genetic factors. There are, like placental growth factors. There are prostaglandins that are abnormal in the uterus. Having said that, I again come back to the same thing. A happy uterus, right? A happy person. So the endorphins, the catecholamines, that the hormones that are released, the environment that you are exposed to, the plastic that you are using, the overall BMI that you have, so many things come together to give you that happy space where a pregnancy can grow well. Many times in these patients, and I'm sure Hemant will agree, that we do extensive investigation and not find a problem. What can we tell? That's where we call tender loving care. We listen to them,
Yeah.
we talk to them, we give them positivity, we tell them some lifestyle modification, and voila, next step pregnancy is all good. So let's not do a blame game that I have and other blame game. Any patient you have a problem, you say you need to lose 5%. I have thyroid, madam. What has thyroid got to do with you're not able to lose weight? That was ek zamane mein when thyroid was big problem and nobody was treating it. Hypothyroidism very big. Now
I know.
1 or 2 grams over and you are thinking you can't lose. So we have to learn that health is our wealth. We have to take care. I sitting in this chair cannot make you better. And I tell them,
That
don't
is
come
true.
waste your money on me. Go spend it on buying some fruits or something and eat it. So it
That
is
is true.
in the ball is in the on the women's court. Today you take this, that I will take care of myself. I will eat better. I will sleep better. I will think positive. Have the problem gone?
Thank
Don't
you. We
always
have only 1
search.
minute.
Don't always
Yeah.
search for an alibi or an excuse.
Yes.
What Madam is trying to say.
So, yeah, we have only 1 minute, but I have an interesting social question. So this is an unmarried girl who has been diagnosed with endometriosis and put on an OC pill. Now she says, when should I stop this OC pill, and should I speak or disclose my condition to prospective groom, and will it affect my fertility?
Can I take
Madam,
this call?
for you. Yes,
Okay.
please, madam.
Okay,
I'm
so-
unable to answer this.
I will, because it is no social cause. There's no social information here. Okay.
Yeah.
Oral contraceptive pills, nobody should shy away from taking if they have a suspected endometriosis. That's the first line of treatment. Now, so if she's taking, and if somebody is convinced that she has endometriosis and she's symptomatically better after taking, let her continue, because it is not going to harm her in the long run. Remember, oral contraceptive pills 5 decades ago was made for normal women for contraception. If in 5 decades anybody had found that it's causing lifelong problem, it would have got banned. It's not banned. So taking oral contraceptive pills is not going to cause any adverse fertility outcome in these patients. Remember that. If endometriosis, it will benefit. Second question. It all depends upon how severe the endometriosis is. If the endometriosis is not very severe, you are just subtle endometriosis and somebody is giving oral contraceptive pill, you don't want to tell your partner, I'm fine. But if you have severe endometriosis, it is better to disclose, be open before you actually get into a relationship than having a problem later. It's much worse. Okay. So endometriosis ke saath, it's a lifelong problem. Sometimes you will have pain, sometimes you'll have problem in having sex, sometimes you'll have problem in getting pregnant. All this will affect your partner.
That
right?
is true.
So it's
Thank you.
like I say, reproductive function or the uterus is not your own. It's your husband's as well. I'm sorry to say very frank things like this. That's simple reason I don't do anybody's instructing unless the husband also comes and signs. The lady is adult, she can sign and say, get my uterus out. But I said, it's a social thing. You have to, together take that call. It may be inside your body, but it affects that guy. So be open. See, if somebody can understand you like this, they'll respect you lifelong. If not, you'll have trouble.
Yeah, completely understand. I have gone over time, but we have had an extremely engaging discussion, and thank you so much, both Dr. Sinha as well as Dr. Kanoje. It was a pleasure, and I'm going to come back to you for another session. This was fantastic. Thank you so much. And on behalf of all our readers, we are really grateful that you could give us your time, even though you're a very, very busy physician. Thank you so much once again.
Thank you so much, Rama.
Thank you so much, madam.
Thank you.
Have a good evening, madam. Ruma, madam. Bye.
Bye, Hemant. See you
Bye.
sometime. Bye.
Bye.
See you, ma'am.
Bye.
Bye.